regards to one of the first of a series of presentations based on pediatric dermatology. I am Dr. Amjad Khan. I've recently joined Shifa International Hospital, and I'm the first Western-trained pediatric dermatologist in Pakistan. And here we offer or we run the first purpose-built or purpose-run pediatric dermatology clinic at Shifa International Hospital. And you can see I've been trained extensively in UK, especially at Great Ormond Street Children's Hospital in London. Then I worked as a consultant at Queen's Hospital in East London. And I was also trained in Bristol Children's Hospital and worked in University Hospital, North Durham. Now, today my presentation is based on the new condition, which most of us have, well, all of us have heard about, and most of us have seen, at least on the media itself. Covid-19, it's a new disease. It's a new pathology, and all of us are getting used to it. It does have its own systemic involvement, including the biggest organ in the body, which is skin. So we will talk about that. So before I start the talk, some disclosures. The faculty, speaker, and the committee, we do not have any relevant financial relationships with any commercial interests or any other organizations. So COVID-19 is a new disease for most of us, and the pathology or pathophysiology is still under observation and under investigation. It's still not very much clear, and it's dependent on different theories offered by different colleagues across the globe. Now, this is a spectrum of disease. It includes skin, which is the biggest organ of the body, but other parts of the body, and most of the time, the most important is the breathing or respiratory system. Now, skin manifestations can be subtle and can easily be missed. And here in this presentation, I've tried to gather all the relevant and up-to-date evidence from different groups and different publications across the globe. And I would like to share a few cases, although one or two of the cases are from other centers, but the ones we have seen here, unfortunately, we couldn't get the relevant consent in time to publish or present here in this meeting. Now, introduction to the coronavirus, most of us know now. Unfortunately, it has affected all of us across the globe. Most likely, it originated in bats. Obviously, again, it's a theory, still needs to be confirmed. But we do know that it spreads with close contact, with respiratory droplets, and yet there is no evidence of vertical transmission or transmission via breastfeeding. Obviously, this can change, but as it stands, that's what we're talking about. Now, 95% of patients develop symptoms around the 13 days, and hence the quarantine period was established. Now, here I would like to take a sort of a pause and involve all my colleagues, suggesting that all the questions and answers we can have a bit at the end of the session. So please do, I will encourage you to drop your questions on the lines, which is available here. You can write it down, and my colleagues will share it with me, and we can talk about it at the end of the consultation or this conversation. Now, what are the possible mechanisms of skin involvement with COVID disease? So it can be either the virus, which could infect an open wound or broken skin. It can be the cutaneous manifestations are related to immune response. And the last one is the skin manifestations possibly caused by new prescribed medications. So if we think about this condition or this disease, the last two are more relevant, or second and third are more relevant. And that's what we will hang on to. So let me share my first case. So this is a 13-year-old boy with pain in his feet. One day history of a little bit of fever, viral symptoms, myalgia, headache, but no breathing issues, no respiratory problems. Now, again, as part of our holistic approach, when we take the history, the family history, so father had mild flu-like symptoms and mom had cough. His vitals were unremarkable, were normal. Now, on the plantar surface of his feet, he has had multiple tender, which are obviously painful, erythematous papules, each measuring approximately around a centimeter. Now, obviously, I will, because I can understand there will be quite a few medical students joining us, and different level of training of my colleagues. Obviously, some very senior and experienced, some not so. So that's the reason I will like to cater for all, and I might explain things in a bit of more plain language as well. Now, with regards to the erythematous macules, there's some petechiae were noticed. So these are non-blanching spots, and they were noticed as well. I will share some photographs in a while. Just give me a few minutes until the next slide. And the interesting thing was this was mostly on lower extremities. Again, we'll come to that, why this is more important in the context of this disease. Now, when the PCR was done, it was positive for COVID-19. So just on this slide, we have quite a lot of information, and we will talk about other associated things, like involvement of the lower legs. So what the statistics now tell us, how many are usually involved with regards to the COVID positivity. And because now the research tells us 2/3 kids are positive, 1/3 are negative. So it can still be a negative person, negative young person, but have COVID related skin manifestations. Now, this was a good case where the child settled. There was no severe symptomatic issues. Systemic involvement was minimal, and the skin changes recovered fully within 2 weeks. I will share with you, obviously, one mild case, one moderate, and one severe. So this is the mild one. Here you can see the photographs, erythematous maculopapular lesions on the lower extremities, and reportedly they were tender. So the child was complaining of pain, and hence the pain, walking was a little bit difficult for him. But again, came out or resulted in a good outcome where within 2 weeks everything was settled. Now let's talk about a bit of relevant data around this. So the cutaneous manifestations in one of these studies, all the references will be on at the end, one of the end slides. So the cutaneous manifestations roughly present around 9-10 days. Erythema is the most common one. So you can see 44% or around half of them have erythema, chilblain-like lesions. So this is very important. Our second case is actually chilblains. So I will talk you through those, the signs and symptoms, and we'll talk about the treatment at the end. There are a few treatment options which we can help our patients with. Now here you can see the last 2 lines on the text, that out of this cohort of patients, 2/3 were positive, 1/3 were negative, and this is pediatric data under the age of 18. Now, evidence-based review here, the reason I have shared this, you can see, that's what I was alluding to in the earlier slide. 50% or half of, or 55%, more than half of the patients have acral or limb involvement. So either arms or legs. Legs are more common as compared to arms. And you can see 20% develop cutaneous manifestations as a whole. So 1 in 5 COVID patients will have some sort of skin involvement. And on the other side, 10% of patients will have cutaneous involvement at the onset. So that's the reason that's more important in our ER, in our emergency department. We have to think outside the box. Yes, we have to check for infection with the other pathologies relevant to the presentation, but we have to keep COVID in our differentials, despite if the young person presenting with to our emergency room, emergency department has no other systemic involvement. So that's the reason I've shared the first case. Clinically, symptomatically, much better, minimal symptoms, only the rash, painful, a bit of history in the family, but was PCR positive. So please keep that in mind. This is obviously the better end of the spectrum. Now, this is from Oxford. They have, this is a pediatric and adult. So they presented this poster. So I've shared it with you with regards to the photographs. And you can see the spectrum from green to the end with red. They very kindly have put it in a visual way, where you can see pernio or chilblains on the lower end of the or green end of the spectrum, then amber as urticarial, vesicular, morelliform rash, while on the other end, extreme end, you can see the purpura and extremities and on the buttock area. Now, this is also more important because one of our patients, adult actually, but in our intensive care back in London where I was working, had sacral necrosis. And again, nothing was positive anywhere on the body on examination, but when we turned the patient around, we found this. And again, the patient was already known to be COVID positive and hence was in intensive care and on support. So there are so many things we have to keep an eye out for our patients because of this new disease. Now let's talk about case 2. And the case 2 is a happy, healthy 14-year-old boy and no health conditions. But he was PCR positive for corona because there was family history. He was tested and no problems. Again, so that's another good point, or that's another statistically important thing for us, that kids have minimal symptoms, but the complications can happen even beyond that 14 days period of quarantine. Our general public, the people I talk to, unfortunately, they have, and even our junior colleagues, and because it's a new disease, they have a sort of a perception that after quarantine period, everything is hunky-dory, there is no problem, and here you go, life is back to normal. Unfortunately, this disease, even the quarantine period or the initial infection period is different, but the body is still fighting the virus. The body dynamics have changed because of corona, and things can happen beyond that period. So that's the reason I've shared this patient here. You can see a young patient, otherwise completely well, corona positive or COVID positive, was no problems, no systemic involvement, and kept it at home. But after a few weeks, nearly 3 to 4 weeks after everything started, he started to develop itchy red toes. So initially it was only itchy and red. We'll talk through as the symptoms evolve. And these are all the toes. So it started on the both feet nearly together. But it turned out to be more tender now. So itchy, red initially, and then became tender or painful, and then developed blisters. So all of us were sort of confused. This was the start of the COVID. So it was last year, March, actually, if I remember right, end of March. And so this child developed blisters and the feet turned blue. Up until that time, COVID was much sort of taken a bit lightly, generally, and especially in UK. We were not very much worried about it, apart in young children. Obviously, in grown-ups, it's a different thing. But things, obviously, we learned as we managed more and more patients. So he was seen in different ERs. Actually, the family lived in one part of the congested city. So went to one hospital, then the other. And the ERs diagnosed him with frostbite. Actually, one of the consultants said, according to the notes, that this is the worst frostbite I've seen in a while. Bearing in mind, it was March or end of March and start of April last year. And in London that time, the weather is usually good. So it was not very cold. And this cleared up again in a week's time. So again, came and went. So people thought, okay, fine, it's frostbite or chilblains or pernio. That's another name for it. So don't worry, things will get better. What happened? So let's show you the initial photographs, then we'll talk what happened later. So you can see erythema, a bit of purplish hue actually, because if you look at the left top corner, purplish hue to the big toe. There is If you see the middle photograph, so it's a maculopapular erythematous raised, and these were tender. These were quite tender. And on the right top corner, you can see quite sort of getting worse and worse. So these are photographs from few days, over few days actually. So why to worry? That's the main point. Why to worry? Because this child represented after a few weeks, his toes were nearly black and feet was purple and ice cold. And the worry for us, for all of us, for our ER colleagues and acute take consultants was there was no pulse in his feet, or feeble pulse, I will say. He was losing circulation to his feet. So it was discussed with vascular surgeons up and down the country, and he was on antibiotics because the loss of circulation gave him a bit of ulcers. So secondary infection was our worry. And then he continued, he improved actually. Within a few days, again, the pulse, within 24-48 hours, the pulse came back. He started to improve. So you can see this is his third episode. Few weeks apart, when he got worse, got better, got worse, got better. So obviously his immune system was struggling, was fighting something, and we'll come to that anyway in a few slides. And so he was given antibiotics to treat the virus? No, he was given them to treat the secondary infection. That's another fallacy. That's another misconception out in community, especially in common people, general public, that antibiotics are given for the COVID. So it's not for the COVID. COVID is a viral infection. The antibiotic is given for secondary infection, wherever it is, chest, limbs, skin, wherever it is. Now you can see here, this is his worst and photographs, quite a bit of scaling in the middle photograph. You can see, even on the photograph, you can appreciate the big toe on the right is slightly swollen, quite painful, I would say, at that time, and quite dusky. So that's the circulation issue at that time. These are photographs from frostbite or pernille from different textbooks. So you can see it's quite sort of overlapping photographs, including this one. So you can see reasonably similar sort of visual appearances. And so it's either frostbite, chilblains, pernille, it's the same thing. And it's usually in response to repeated exposure to cold, but not freezing air, mostly on the exposed parts of the body. Now, what do we know why this can happen, or what's the theory behind, or what's the possibility or postulated hypothesis behind this? It is viral induced vascular damage and secondary ischemia that possibly could explain the pathophysiology behind COVID-19 chilblains. And you can see here the 60,000 times magnified electron microscopy comparable to the mitochondria, how big is the COVID-19 virus. And this can cause endothelial damage. So this is the sort of idea behind or understanding behind. Now let's talk about case 3. Obviously, we are going into the mild, moderate, and severe end of the disease. So this is nearly the worst end of the disease we can think about in young people. This is from America. And we have seen quite a few cases in London as well as here in Shifa International. My colleagues have seen, especially intensive care colleagues. But I'm sharing a case which has been reported in text. Now, this is a 6-month-old young child, previously otherwise healthy, fully immunized, had a day of fever, fussiness, refusal to eat. Bearing in mind 6 months old, most of them will have a bit of cold, tough temperatures, so viral symptoms, nothing to worry about as such. But there was no cough in this child, no rhinorrhea, no congestion, temperature was persistently high. So that's another point here. And laboratory evaluation, baseline, and this was America's influenza swab and urinalysis, the basic septic screen were all negative. So this was, the child was diagnosed, she was diagnosed with viral illness, viral infection, and after safety netting was discharged home, but represented, and this time, blotchy rash. I will show you the photograph in a second, and Sent home again because the septic screen was done only 48 hours ago. So reassured, antipyretics, and was sent home. Third time represented, another 48 hours. This time a bit of congestion, but no cough. Persistent temperature. So bearing in mind, all of us who are from pediatric background, uh, persistent temperature not coming down in a young child, all of us do worry about systemic involvement, including Kawasaki disease. And that's what was at the top of the differential here for my colleagues. You can see tachycardia, tachypnea, but the oxygen saturations were fine. Child was irritable. The other thing which they pointed out was conjunctivitis, but with limbic sparing. And I will show you the photograph. They're very kindly. That's the reason I'm sharing this case, because we have got very good photographs related to and very clear history and a lot of investigations done. So it's a sort of a comprehensive review. Chest X-ray had sort of faint opacity, nothing very clear cut. Now, this child's sibling, who was 9-year-old, had RT or upper respiratory tract symptoms 3 weeks prior to all this started. So now obviously the penny dropped. You can see the photograph, limbic sparing on the conjunctivitis, a child had IV line in situ. Obviously this is because we were thinking, or the team were thinking about Kawasaki disease and the sort of confluent widespread maculopapular rash on the limbs. And you can see on the arms and legs. And now what to do next? What do you think as a pediatrician our colleagues would have done, which very rightly they went down the route of Kawasaki disease. Bearing in mind, this is again early last year, so the COVID was pretty much new, kid on the block was the new sort of disease in our books, in our literature, in our text, and our exposure was limited. And hence, all these type of patients were collated and collected together, and then our medical experts across the globe started thinking about systemic involvement in young children with COVID, and we'll talk about it. Now, this child's PCR was pending, but they went ahead, treated for Kawasaki disease, which is the standard treatment. All of us know from pediatric background, IVIG, salicylic acid or aspirin, and echo. Echo was negative, and the RT-PCR was positive for COVID-19. Public health was obviously notified at that time, which was standard practice in United States, and the child was sent home on aspirin and was asked to quarantine. Here again, at that time we were more focused on the quarantine period, but this child later turned out to be the disease was named later, but this child had what we say pediatric inflammatory multisystem syndrome temporarily associated with COVID-19, or PIMS-TS. So PIMS-TS is a multi-system disorder. Not within the first 14 days, it can happen even beyond that. And this is again, you can see the number shared here. It's quite a lot, 953 patients over the period of 8 months, and different body organs involved. But mostly, if you, the more important thing which I wanted to you to sort of focus on, if you see here, is that 2/3, if it's PIMS-TS or the patient is systemically unstable, 2/3 will end up in ICU. So the earlier we involve our intensive care team, our critical care team, the better it is. And the median stay around is 4 to 5 days, you can see here. So, you know, at the right top. So this is the sort of outcome is the more important here because of the systemic involvement. So it is a disease which can have mild spectrum, moderate, and then this is the worst end of the spectrum of the disease. Now, hospital management, this is from Spain, so apologies for some spelling mistakes, but my Spanish colleagues have sort of compressed all their clinical expertise in one slide, and hence I wanted to share this, not relevant to the dermatologists. I'm sure you will appreciate that, but for my ER, the frontline staff, pediatric team, and then obviously the intensivists. So, you know, quite a bit of things, which I'm sure you, all of you out there are doing it, but, you know, check-ins, isolation precautions, which we do standard anyway for nowadays, monitoring, supportive care, and then cardiac monitoring. And you can see admission criteria, which Spanish colleagues followed, and the discharge criteria. So this just gives us an idea. We can obviously modulate our local guidelines depending on the availability of resources, and then what sort of things we can do. You can see here echocardiogram, ECG, and markers. Every 3 days they were repeating them. So this is just a sort of a basic background information. Now coming back to our topic. So this is Royal College of Pediatrics and Child Health, their PIMS TS guideline. And you can see here, the reason I've shared this is at the bottom of the page, PCR for COVID can be positive or negative, because I've seen a lot of patients, at least few dozens patients presenting, young kids, teenagers presenting with the acral sort of purpuric or petechial patches systemically well. Some had COVID, some never had COVID. So those whose families used to ask questions, if he hasn't had COVID or she hasn't had COVID, how he or she can have these symptoms. So it is not only the positivity of the test, it is possible, you can acquire it from your surroundings, and then you can have subclinical disease as well, or subclinical response. Now, the PIMS TS here, you can see it's relevant to dermatologists, my colleagues, because it's a rash, mucocutaneous lesions, and conjunctival injection. So hence that conjunctival injection photograph I've shown you from the young 6-month-old is more relevant and more sort of obvious for us now. Now, spectrum of maculopapular rash. So it is a very sort of broad term, maculopapular rash. It can present in different ways, different parts of the body. And you can see in different types of skin here, Caucasian skin, you can see slightly darker skin as well. It is non-specific. Now, obviously with COVID, the question arises, what type of rashes do present with COVID? So my colleagues from different hospitals, again, this is a publication, the reference will be available at the end. You can see initially we thought 5, now we say 6 types. Again, our understanding is evolving. 6 different types of rashes are involved with COVID or present with COVID. Urticarial rash, the first one, is the most sort of common one. Limbs and trunk is more involved. You can see all here through and through. Face and neck is the least involved part. Mostly it is on the limbs, sometimes on the trunk. And so it's not only urticarial, it's a morbilliform, papillovesicular, chilblain type. Again, I've shown you a case. Livedo reticularis, it's more in adults than in children. And then obviously purpuric spots as well. Again, few further photographs sharing for urticarial rash. You can see quite widespread vesicular. Now, this is a bit of confusing here. I wanted to bring it to our attention. Rather, now, what happens once we are more tuned up for one disease, all of us will focus on that, but we have to keep broad mind. We have to think outside the box. So that's the reason I'm sharing this. Here you can get easily confused. Now this is, yes, I can understand and I can share with you, this is COVID related because this child had that. But on the other side, I'll show you the next slide, which is something similar, especially on arms and elbow area. So it can easily be confused with another viral illness or viral rash, infantile papuloacrodermatitis or Giannotti Crosty syndrome. That's what we label it as. It's a viral exantheme, it's a viral rash, and mostly asymptomatic. Systemically, child is usually well, sometimes can have associated fever, but this rash is there. And now with this, usually around the joints, some kids can have issues with the mobility. So just think outside the box. If there is rather than only legs, if it's on arms as well, and there is issue with the joint pain, then think outside the box and look out for other causes. Now, let's talk about the treatment options or what sort of treatments we have used, or our colleagues across the globe have used and found it helpful for cutaneous manifestations. So urticarial rash, you can see it's predominantly trunk and limbs. Angioedema has been reported, but is reasonably uncommon, and it is reasonably severe. So it can be intermediate and severe. It's not on the usually milder end, it's on the moderate and severe end. Now, what sort of therapeutic options we have? All of us use for urticarial rashes, we use antihistamines. The stronger, the better for this type. You can use low dose systemic corticosteroids and with non-sedating antihistamines. So this is one of the places where you can justify using steroids, but obviously once you have made sure that the child or the young person is sort of either COVID positive or there is a strong history, and you have ruled out other pathologies because obviously you're giving systemic steroids. Coming to the morbilliform rash, you can see it's mostly generalized, symmetrical. So that's another thing, symmetrical on the trunk as well as on the limbs. And so topical steroids are usually suggested or advised here. Depending on the severity, depending on the symptoms, you can use moderate or even potent steroids if need to be, depending on the age of the child. And sometimes, like in severe cases, you can use systemic steroids. Now, with regards to the other three cutaneous manifestations, which you can see papillovesicular, chilblain type, and lividoreticular sort of pattern, we usually say wait and watch approach is always better. Better not treat them because you have seen the case we have shared here today. It resolves on its own. So I have seen one or two cases which they were severe and quite pretty bad than the one I've showed here, and the chilblain type, and they ended up getting strong topical steroids or potent topical steroids. Still, the systemic steroids are avoided. So see how your patients are. I'm sure all of us clinicians do categorize our patients in mild, moderate, severe, looking at their age, because pediatrics is a very versatile specialty where you have babies, you have got young kids, preschool going, then school going, and then you have teenagers or adolescents, so or young people. So again, the area of treatment or the options of treatments depend on the clinical situation. Now, coming to the last variety, which is the vasculitic or purpuric type. Wherever the purpura comes, or most of us are training pediatrics, we'll think about meningitis until proven otherwise, or other infections. So once those are ruled out, and there is a strong possibility either PCR is positive or there is a clinical correlation, and we are thinking about COVID, then topical steroids can be used for mild disease. Again, systemic steroids can be used for severe cases. And the references are obviously present here. Now, this is, if you think about the second slide I showed you about the theories, this is the third theory, that the skin manifestations or cutaneous manifestations are due to the new drugs we are using. Again, all of us would have been following this COVID as it's spanned out over the last year and spread to the different parts of the world. And so we have used a lot of off-licensed medications for this. And even now we are using it because there is nothing licensed for everything in COVID. So you can see chloroquine, hydroxychloroquine was at one point thought to be helpful. Azithromycin still is very widely used. Antivirals, steroids, tocilizumab. So this is obviously a biologic agent, and then convalescent plasma. There were a few trials for that as well. So all these have all these interventions, whether they are medications or convalescent plasma, all these interventions have their own side effects, their own presentations or associations, their own cutaneous manifestations. So you can see mucocutaneous adverse effects, which I've tabulated here, again, taken from one of the publications. And so rather than COVID itself, if the young person comes in with COVID, it's RT PCR positive, but has not been treated yet, that rash is different as compared to the one we see in hospital, primary care, secondary care, or tertiary care, where they've already been given a lot of medications to help out different parts of the body. And then we wouldn't have that clean slate or single type of rash which the child or the young person came with. It will be a mixture of others associated with the medicines itself. So always think outside the box, and your treatment or our treatment should be directed towards specific triggers or specific occasions. Now, last but not the least, the take-home message. Unfortunately, although most of our academic or healthcare focus has been on COVID in the last 15-18 months, but still our understanding is far less than what we would have hoped for or we would have aimed for. There is no sort of single fantastic treatment for COVID, but our understanding is getting better as the time passes. So what I would suggest my colleagues, keep an open mind. There is a lot of information out there. Talk to our colleagues in the MDT teams and our other specialties. We learn from each other. So it's not that one person is isolated and the other specialty is isolated. We all work together for the improvement and betterment of our patients, and hence our understanding improves with time. So you can see again 6 different types of rashes associated with COVID. So the take-home message is again that please do continue to explore, and we need a lot more data to see what other skin manifestations are, or what are the specific treatments, how we can help our patients to improve and be more comfortable. Now, these are the references, and what I would suggest, if anyone is interested, they can further read. And before I say close the talk and say goodbye, these are the 2 associated issues, possibly because of the COVID has been magnified on, has accelerated. So interestingly, some people have termed them under one term called as maskne. So one is mask-related dermatitis, contact dermatitis. It's the first left top photograph, and the second one is acne. So anyone who has acne, that can flare up because of wearing the mask. So it's a maskne or COVID-related skin condition. And before we can go to the next slide and start taking questions, the other thing I would like to mention, quite a few people have started using the term COVID toes, and that's available. You can Google it yourself as well. So COVID-related this toe issues or chilblains, they have been termed as COVID toes. So again, don't get confused. If you read it somewhere, or if you want to Google it, then you can find further about it as well. So at the end, I will say thanks to all of you who have taken the time out and have listened to and participated in this talk today. And I would like to take questions if you would like to ask any. Okay, so the first question here is, does these itchiness is limited to toes or it's spread to other parts of the body? Well, the research as it comes out, the papers, what we hear and learn, because this is an immune mediated response, it does start on the limbs, but it can spread to other parts of the body because it's an immune mediated response, and hence, unfortunately, it can be more widespread. But non-sedating antihistamines can help if the pruritus, or the medical term for itching, if pruritus is significant, then please do consult your dermatologist. They might consider giving you topical or oral steroids. So there are other options. Now, the next question is, please provide the slides to the attendees. I think our presentation will be available on Shifa International Hospital's YouTube channel, as well as our social media. So please do stay tuned for that. Now, the question from one of our attendees today is, can aspirin be given to COVID-19 patients? Are they more effective as compared to antivirals? Well, again, it's COVID-19 management is not managed by single-handedly any one specialty. It's a combination of MDT support. Aspirins, there is evidence out there for so many medications, not only aspirin. You can see I've shared a slide, hydroxychloroquine, then azithromycin, and so many other medications. So as we go, we will learn more, but there is no single evidence, or there is no concrete evidence that it is more effective as compared to antivirals. Now, next question is, what is the possible pathophysiology mechanism behind vascular damage by COVID-19? I mean, what actually virus do which leads to vascular damage? Well, that's a very sort of scientific question. And you can see our cells are naturally, they have their own hemodynamic environment. Any outsider, any pathogen, that it's just like any other pathogen, COVID-19. It's the main idea is we are more concerned or more aware of it, but there are so many other pathogens. So any pathogen which comes into our cells or our hemodynamic environment, our immune system will get triggered. So it's not only the virus itself, it's the immune response against it that can cause the damage. And that's very true for all the autoimmune conditions. So, there are so many autoimmune conditions which we worry about because it's not the disease itself, it's the immune response of the body or the immune reaction mounted by the body, which can cause secondary damage as well. Now, the next question we have got is how to know whether the skin condition due to reaction of any medicine being used in treatment of COVID or due to coronavirus itself. Yes, how to differentiate. So thank you for this question. I think I've answered it at the end of my presentation. If the young person or even a grown-up that comes to our ER, our emergency department, or you see them before any treatment is initiated and they have got cutaneous involvement, that's obviously because of the COVID itself. Afterwards, obviously, it's a bit difficult, but if you look at the sort of drug chart, if it's a fixed drug eruption, if it's related to the drug itself, like anaphylaxis, there will be quite evident clinical correlation. Then obviously hair loss is not reported for the COVID, but has been reported for the other medicines, like in my last slide. So there are quite a few clinical cues we can pick up as we see our patients. So let's go to the next question. Okay, I think the next question is a bit personal. Someone wanted to ask medical opinion. I will encourage you to consult a dermatologist, or if you are local, please do come to our outpatient department and we can help you out with your treatment of your face and your rashes. Now, the very relevant question posted by another colleague who has been listening to us, that can chilblains or frostbite or pernio, if left untreated, lead to gangrene. So COVID-related chilblains, it can result in gangrene. It's been reported. But in young people, it's not reported. It's more reported in intensive care patients. If you remember, I've shared a photograph where there was a bit of superficial excoriation, sloughing, and a bit of gangrene on the lower back or sacrum of the patient who was in our intensive care. So yes, it can lead to not only in toes, but in other parts of the body. It depends how bad is the immune reaction, how bad is the infection, how systemically unwell the person is. So I'm sure my intensivist colleagues, if they are listening to this talk, they would have seen gangrene or at least critical blood flow issue to different parts of the body in patients with COVID-19. Okay, now the next question is, I think it's a general question for COVID-19, not relevant to the skin, regarding the treatment options. Again, what I would encourage my participant who has requested or asked this question, COVID-19, here we are obviously talking about the cutaneous or skin manifestations, but COVID-19 treatment is managed by a group of individuals, not one person itself. And there are so many treatment options. Again, most of them are unlicensed, but with the experience in treatment now in the last year, they are being administered. So if you have any COVID-related systemic issue, or you are wondering about treatment options, then we do have a COVID response team here at Shifa International. So you can, I'm sure you can get in touch with them and they will be happy to answer your questions or treat your patient. Let's go to the next question. All right. Well, I think the last question sums it up all. The participant has mentioned about something which has been going on the social media. Mostly, these posts on social media are fake news. People want to get social viewings. They want to get. I'm sure you are aware. YouTubers, Instagrammers, they do get paid. TikTokers, they do get paid for the more views they have. So a lot of people do encourage a lot of rumors so that their channel or their viewings can go up. It is so unfortunate. It is uh, so sort of unethical, and I'm sorry to see these things happening. But unfortunately, they do. So the last question is relevant to that because someone, our participant, have heard or read on the social media about the vaccine and associated issues. Somebody has been spreading the rumors that people will sort of have mortality after a few years or 2 years or whatever it is. All of these are fake news. uh, Whoever works in medical industry, especially pharmaceutical industry, they know how stringent the criterias, the guidelines, the safety is, and how seriously world over, if a disease, if a drug is coming out, how seriously the industry and the countries and their monitoring organizations take the safety and efficacy of the medicine or the drug. So please do have faith in the medicines offered to you if they are licensed, especially the vaccines. They are life-saving medicines. They are game changers. And if we don't sort of listen to our colleagues who have given so hard work, they work day and night to produce it for us. It's us who are going to suffer, not them. So please don't listen to all these rumors and fake news. And I will encourage all of you and to have the vaccines done yourself if you haven't yet had it done, but also encourage your families, your friends, and your sort of work colleagues and your network, all of them, to get vaccinated against this horrendous disease. And let's save the humanity. This is a pandemic. The last pandemic was nearly 100 years ago. This is in our lifetime. This is what we can reflect back on and tell our youngsters that we have given and attributed and contributed positively to this pandemic, whatever we can. So wherever you are, wherever you are listening, whatever you do, don't worry. All of us can positively contribute towards the pandemic improvement and towards the humanity. So thank you very much. With this, I think our question and answer session completes and finishes. As I was mentioning earlier, I do offer the pediatric dermatology services. I'm the first Western trained pediatric dermatologist in Pakistan, and at Shifa International Hospital, Islamabad, I run the first purpose-run pediatric dermatology clinic in the north of the country. And I will, if some of you are trainees, I will encourage you to get in touch as well. So if there are any questions, I can answer that. And thank you very much for all of you for joining today, including our CME team that have helped me organize this. And stay tuned. We will be running pediatric dermatology emergencies or ER presentations, a series of lectures soon for our trainees and doctors across not only the country but across the globe. So thank you very much for your joining in today.